Okay, Angela and Nancy, we have participants are joining us now. Let's give it about maybe until about 1:02 or 1:03, if that's okay.
Sounds good. Thank you.
Yeah.
Great.
I always think when we're doing this, we should have some background music.
I know. Or maybe one of those things that dance across the screen.
I don't know. But I do know it wasn't too long ago, I got into an elevator in a high rise, and I was starting to rock it out, and then realizing that they had Muzak, the Rolling Stones Paint It Black, and I felt really old. Give it one more minute. Nancy and Angela, are we okay if somebody comes in 5 minutes late? That won't hurt their CEUs, will it? Are we okay if we start about 1:02?
Yes, that's fine.
That would be
It's a
fine.
minimum of 45 minutes, Joe.
Okay, good, good. Okay, well, we have 1:02. We have 49 participants. We have 50 participants.
Yes,
Angela and Nancy, are you okay if we get started?
we are. Yes, let's get going.
All right. Well, everyone, thank you all so much for joining us on Cracking the Code, Addressing Common Problem Areas in Medical Documentation and Coding for Compliance and Reimbursement. Today we are granting, or this course has CEUs from AAPC attached to them. We do need you to stay online for 45 minutes or more. Hopefully you're excited and you want to stay for the full hour, but for 45 minutes. And we are recording, and we will be issuing your credits as long as you're here for more than 45 minutes. Next slide, please. So, hello, Joe Ferro, president of CommWaters AI, a little over 32 years now in coding and compliance. Angela?
Hi, I'm Angela Jordan, and I have been in healthcare for over 35 years. I am a CPC. I am a certified professional medical scribe, as well as a CBOGC. Nancy?
Hi, good afternoon, everybody. I'm Nancy Entwistle. I'm the EVP of Regulatory and Coding Compliance. I too have also been in healthcare for over 35 years. Well, that makes us all sound kind of seasoned, I guess. I have an RHIT, CCS, CCDS, and a bunch of others that I'm not going to bore you with, but I'm very glad to be here with you today.
Great. Well, thank you all. Go to next slide. So real quick about CommWaters. So we are a AI-powered autonomous E&M coding platform that lives within your EMR. So we sit right at your clinician's desktop, helping them automate and very highly compliantly and accurately level their E&M code or codes. So with the goal of bringing order, compliance, and standardization to a very subjective, costly, and difficult process. Next slide. Okay, so before we start, there's a couple housekeeping items. One, we already talked about the 45 minutes. At the bottom of the screen, you will see that you have a couple buttons. One is the chat button, and the other is the Q&A button. If you have any questions during the presentation, please go to hit the Q&A button, and you can submit the question. At the end of when we're done with the presentation, hopefully we'll have time left over, and we will go through your questions. If we are unable to answer your questions during the presentation, this training session, we will answer them and send out the responses via email. So whether we answer them now or later, you will get an answer to your questions. Also, we will have some poll questions throughout the session so that you have some interaction. And if you can go to the bottom chat button, that you can answer the poll questions. So that's it for my housekeeping. Angela and Nancy, if I can pass over to you.
Absolutely. Thanks, Joe. As a footnote on that, your CEUs and your presentation will be sent to the email that you registered for this webinar on. So if you are in a group of, in a room with a group of you, it's going to go to the one who ended up registering for today's webinar. A disclaimer, which we'd like to say, is that I'm sure everybody is very aware that there are changes happening hourly, not even daily or monthly at this point, as we're getting ready for the 2024 changes. We want to let you know that the presentation as today is the best of our knowledge of what we have as far as documentation, and that's been published by both AMA and CMS. And we always refer you back to the official guidance, guidelines, and criteria set forth before making any final decisions. We're just here to make you aware of changes happening, but we are not the authoritative on any of this. CMS and AMA is always our go-to. Next slide. So let's get this started going. We have a poll question. With the holidays now upon us, what is stressing you out the most? Angela, what's stressing you while we have people answer in the chat below?
Well, to be honest, I'm just a tad bit behind on Christmas shopping for the grandkids. So this
Oh, well,
next
that's
week is
important.
going to be very hectic, I should
That
say.
is, yep, that's important. Joe, how about you? What are you stressed about?
No stress.
Excellent. Well, there you go. You're already, you're letter D. I'm going for letter E, Wake Me in January. I love Christmas. I love the season, but I am a skier, so I'm waiting to get up to the slopes. So that's what I'm waiting for. So let's check our responses, see what we have in here. C, we have a lot of C's. We have a couple of D's. Gift wrapping. A funny story, I used to work at Sears a long time ago, and I was always assigned to do all of the store's gift wrapping for everybody. I learned how to wrap really neat, really quick, very quickly. So, but gift wrapping is a big challenge. That's why they make gift wrapping bags, I guess, huh? All right, enough fun. Let's get to the actual presentation. Next slide, please, Angela. And I am going to let you take over here.
All right, I'm going to jump in. Okay, so basically what we want to talk about today is we are focused on evaluation and management. And while there were the changes that occurred, of course, they started in 2021, and then, of course, this year. And then what we're really focused on is just the evaluation and management services. And then as we go through this presentation and how along with procedures, and we're going to talk about good old modifier 25, is that's really the focus, because when you have surgical procedures and things like that, there's definitions and they're pretty, most people with the operative report, you can get to the meat of the code fairly quickly. But when it comes to E&M, even though they've really given us some great guidelines, the problem is it's still subjective. And some of the definitions, and we've met with some physicians that they've seen the grid and they're using the grid, but they've never read the guidelines. So they're giving themselves credit for things they shouldn't and things like that. So what we're going to discuss during this presentation today is things that we still see every day with our clients that are using our system. So the first thing I want to talk about is the external review of records. Now, the AMA recently had a, I believe it was a CPT assistant, and they even went over it in the CPT symposium, that when a physician reviews their own record, that's automatically part of the pre-work. It's already valued into the E&M code. What the physician gets credit for is when they are reviewing external records. So if a provider just simply says, I reviewed records, an auditor's not going to give them credit for it, and a payer certainly isn't going to give them credit for it, and most likely the coder won't either. So what we really want to impart to the physician is when they're doing their documentation, they need to understand what the coder, the payer is going to be looking for. So we've got some examples here. So The first one is the patient was initially evaluated at Christiana Care on 4/26/23, where radiographs were obtained and a fracture was diagnosed. Reduction was not performed. Now, the patient could have told me this. It doesn't say that I actually looked at the records. This could be history coming from the patient, but the next example, records indicate that the patient was initially evaluated at Christiana Care. Now that shows me that that physician actually looked at the records from Christiana Care. Then what's even more perfect is external records indicate. So you can see how with just a few words, it makes it more clear to the reader of the documentation. Then the other area that physicians still every day, when I get queries from providers about something maybe not looking right, physicians still think they get review for something they ordered at an encounter. So the one thing when I'm working with physicians to understand the difference between the data elements for review and the data element for ordered is that you can only count the review if it was something that was ordered between encounters, or it's something that's called, you might call it a standing order. CPT called it a serial order, where you say you want to have the patient to have a PT before their appointment the next year. Well, in that instance, the second or third time the patient comes in for that visit and they've had their PT drawn, they get to count the review because it's not the order. So making physicians understand the difference helps them to better grasp how they need to document so that either your coder, your auditor, or your payer can clearly give you the points that you deserve. So is there a difference between an independent historian and independent interpretation? And the answer is yes. And I'm going to kick it off to Nancy.
Excellent. Thank you, Angela. Before we do that, I just want to let everybody know on some of your instances of the Zoom chat is not working. But if we have poll questions, please feel free to use them in the Q&A section. Thank you for all of those who alerted us that the chat was disabled. We have another poll question coming up soon, so please feel free to answer in the Q&A section. And thank you for your patience. So back to independent historian. Now, what the heck is this? I hope at this point everybody is very aware of this. However, I do want to say the official definition by the AMA. The AMA defines an independent historian as an individual, meaning a parent, a guardian, a surrogate, spouse, or witness who provides a history in addition to the history provided by the patient, who is not able to provide a complete history or reliable history due to developmental stage, dementia, or psychosis, because the confirmatory history is judged to be necessary. Now, that's a lot of almost the same information coming again. Again, this is the AMA sending this one out. Basically, in short order, what it is that if you have somebody who is in the room with the patient, providing additional history to the provider, qualified healthcare professional, practitioner, then you as the provider can document that. And it has to be documented that information was provided by a separate person other than the patient in order to get credit for this. So an examples of these is a pediatric patient, due to their age, is not able to converse directly with the physician. Although children are very chatty when they're young, they might not know exactly what's going on. So if a parent or a guardian is in the room with this patient and providing information, then that is a reliable piece of information that can be documented as an independent historian. The next one we have is an elderly patient with dementia or a prior stroke that has left them nonverbal, and they have a caretaker or somebody who is on their speaking on their behalf about everyday life or whatever is happening prior to the visit. They can now be considered as an independent historian. A mental health patient who is not a reliable historian. Sometimes when mental health patients go off their medications, they become very unreliable with their actual medications, what they've taken, what they haven't taken, and when their symptoms may or may not have started. So somebody who is an advocate for these patients are then considered an independent historian if they're providing documentation to the provider during this visit. And then finally, a trauma or an acute injury patient who cannot give a full history. Obviously, if they're injured and they are not able to speak or are not conscious at the time, somebody who is acting on their behalf becomes their independent historian.
And I just want to interject something here real quick before Nancy goes on. I have attended a couple of the MAC sessions recently on E&M where they've tried to clarify some things in their standpoint. What I want to say here was something that actually kind of surprised me by one of the MACs is that for an independent historian, they are going to be looking for documentation that clearly indicates why an independent historian is needed. So simply because the patient has Alzheimer's, it almost sounded like they were stating that you would have to put in your HPI, wife is giving HPI or providing history due to he's an unreliable historian due to Alzheimer's. So just wanted to kind of throw that out there.
No, and that's very good information, Angela. And I think that hopefully will clarify some of the confusion, because I have seen some notes that practitioners, providers, or QHPs have been putting that the parent was in the room. And I'm going to give you some examples as we speak. So here's an example of well, let's go over this and see if these are qualified or not. How's that sound? A 14-year-old male presents with his mother today for an evaluation of his left shoulder. His injury was sustained last night at football. He says that his coach had to relocate his shoulder. Would this be a good example of an independent historian? Not at all. So the student, the 14-year-old, is indicating that his coach did do something, but however, the coach was not there and did not provide information to the provider, nor was it documented by the provider that this coach provided any information. Our next example is a 2-year-old girl that presents today for evaluation of a left elbow injury. The parents state that she has an immediate pain and screamed very loudly after one of the pulls. Would this be considered an independent historian? Absolutely. The parent has given information to the provider indicating what happened immediately after the injury and how the patient, this 2-year-old, had responded immediately after the pain. Next slide. So some of the differences also that we want to talk about refers to interpretation. You're trying to see if I'm on my toes. I see that. Refers to an interpretation of a test where there's a CPT code. An interpretation report is customary. This does not apply if it has been previously reported by a service of the patient. Angela, I am going to actually let you take this one.
Angela, you're on mute.
I caught it. So this is actually one of my favorite ones in working with physicians is that especially when you work with Medicare, most of the MACs are very clear about the documentation has to clearly support whether you looked at images or whether you were reviewing a report. And so I've seen some documentation both in the ED, in the office, in the hospital, where the language is so loose, you can't really determine if they actually looked at films or the images or the pathology slides or what it might be, or if they were simply reviewing the report. And so Medicare basically has said, if we can't tell, then you're most likely not going to get the review of the images. So what I recommend when I'm working with physicians is to be very clear whether you're looking at the imaging, say I'm looking at the imaging, I'm looking at the x-ray, the CT scans, they were independently interpreted by me, and then your summation. It does not have to be a radiology report like a radiologist would do. It just has to be their, it would just have to be their findings. So same thing here with x-rays. X-rays were independently interpreted by myself from an outside facility and reveal a 9-displaced distal phalanx fracture of the great toe with good alignment. Now, the next one, I'll go ahead and jump on and take. This is the discussion of the discussion with an external clinician or an appropriate source. This is from the AMA knowledge base. And I thought this was a good one because this actually comes up. I know this is a hospital inpatient case, but this comes up a lot in the office setting. It could be cardiology, pulmonology, where one provider maybe does an EKG or an X-ray. They do their independent interpretation. And now maybe the patient is coming back in the second time, and that physician that they've never seen before, we're going to call him Dr. B. Dr. B wants to go ahead and do his own independent interpretation and get credit for it. Well, the AMA says, no, you can't do that because you were both part of the same group, and only one provider is going to get credit for that review. And an external clinician has to be truly external. It cannot be somebody within your own office. It's got to be somebody outside your practice or someone that is a different subspecialty. All right. Now I'm going to throw it over to Nancy for time.
So if you have been paying attention to any of the updates coming for January 1st of 2024, you are aware that the time is going to be changed for the 99202 through 5, as well as the established 99211 through 15 series. No longer are we going to have that the range of time minutes. We effective January 1st, the provider must state that they meet or exceed a set amount of time for total service time before you can bill by code for the time. So CPT has decided to remove the time ranges from both new and established Office and E&M codes and replace them with a single total time amount, which is the lowest number of minimum minutes in the current range for each code. This time must be met or exceeded. Now, I've said that a couple of times, so I want to make sure everybody's aware of that. It has to be met or exceeded, and it has to be documented as such. So according to the new wording that appears in the descriptors, it is going to be something that's going to be watched. So if you are in a habit of using less than, greater than, things of that nature, those are no longer going to qualify you for a higher level. You need to specify the minutes in a total amount of time. What we did here is we gave you a quick and dirty grid for you to quickly reference these changes. So you can see the first column has the 2023 total time is a range of 15 to 29, 30 to 44, and so forth. And then 2024 in the second column indicates the lowest amount of time that must be met or exceeded. Now you could see that they did take the lowest amount, so that instead of going from 30 to 44 for 99203, you have to go from 30, and then the next level starts at time minutes of 45. Additionally, pay attention to the established time, is because those are much different. So you get, instead of a 15 to 29 and going to 15 on the 99212, you get a range of 10 to 19. So they changed the time as well for the established. So they clean that up a little bit. And what they're doing is they're making this to come more in line with other changes that were made in other code sets for the 2023 calendar year. Next slide. So I just wanted to send out some examples to try to help understand what we are speaking about. The physician billed a 99396, which is a commercial annual, along with a 99215 modifier 25 with the following time statement. Today, more than 40 minutes of an encounter was spent on counseling, coordination of care, and multiple medical conditions, including a chart review. This time statement is not clear because the time did not include separately billable services in the 99396. So if you wish to get credit for a time-based code, you must also state what was done during that 40 minutes in order to count the time component. So on the other side, a good example is the physician billed a 99214 with the following statement. 33 minutes of time was spent in preparation of notes, review of records, and discussion with patient and examination. This makes sure that there is no ambiguity in the note whatsoever. It's documented and attested to that, yes, this is exactly what was done in these 33 minutes. And that would be a very good example of how to use the time component for the 99214 code.
Okay, and I'm going to jump in here and I'm going to take on split or shared time.
That sounds like a good idea. Thank you.
Yeah, this is one of those things that is just like, I just love. Okay, so I think the one thing that everyone needs to be aware is that finally CMS and AMA align, and they have now formally agreed on a definition of split or shared service. But the important thing you need to know about this is the fact that previously in the proposed rule, CMS said that for 2024, for split or shared, you could either do time or you could do the substantive portion based upon who did the history, the exam, or the MDM. They reversed it in the final rule. Now it's either time or who provided the substantive portion of the medical decision making. So it could be, remember, in medical decision making is 3 elements. So it's whomever did the substantive portion of the medical decision making. So I wanted to let everybody be aware of that. And the next thing they did is time. There was all this confusion on when and it's not really the office, we're talking inpatient. When an inpatient stay crosses calendar dates, how do you count time? Well, thank goodness the AMA and CMS again aligned, and they now have provided basically the same table that was in the final rule last year on this. So it's the same exact table is now in your CPT book. And so they are following the same guidelines that Medicare does. Now, COVID-19, I'm not going to spend a lot of time on this, but there is a link on our very last slide. It is the resources slide. The most important thing you need to know that as of October 14th this year, the editorial panel approved the addition of new product codes, but then they went and deleted administration codes, and now we only have one administration code, which is, if you've got those matrix, everybody had the matrix, or you were always downloading the AMA vaccine. Every time they would have an update, you would download it so everybody would know what administration went with what vaccine, et cetera. You don't have to worry about that anymore. And so they did state also that anything that had the A has now been deleted effective November 1st, 2023, because of the additional changes. So like I said, again, the last slide, we do have a resource that goes directly to all of the COVID-19 information. Okay, so I get this poll question. Is your group planning on reporting the new Medicare add-on code G2211, which is called the Visit Complexity Inherent Code? So since our chat's not working and the Q&A is, if you want to pop in your answers in the Q&A section, it'll be interesting to see if anybody knows what the G2211 is, or if your practice has even been talking about it.
I know that there's a lot of chatter about whether or not they have to do it. So that I think it'll be very interesting to see where the Q&A's answers will show up. This might be a good time to remind everybody, you get your CPT book and sometimes it's delivered in shrink wrap. You might want to take the shrink wrap off and like dust it off and start looking through it before January, if you haven't already looked at it.
Oh, there's
Let's
a
see.
lot of Ds.
Yeah.
Okay,
Wow.
so okay, so this code, it's called, it got the award for the longest, um, definition, or the longest definition of a code, because it blew the, cognitive one out of the water with the number of words. But basically what this code is supposed to be, it's going to be an add-on code. It can only be billed with an E&M. It can never be billed with an E&M that has a modifier 25 attached. And this is only billed when a physician has what they call a longitudinal relationship with a patient with complex conditions. So this originally was only going to be for family practice, internal medicine, geriatricians, those that seem to be more of like they take care of the whole patient. But then when the pushback came back in 2021, when this code was addressed, they delayed it until they changed it to where now it could be a single complex condition, but that provider still has to continue that longitudinal relationship. It can't be something like, okay, you're cured, go home, we'll see you whenever. The problem is, at this time, there's a lot of speculation out there of what the documentation requirements are going to be. The Federal Register gave some hints, but right now, I think what everyone is really waiting on is to see. Medicare has not sent the change request out to the max to tell them what what the expectations are going to be. So really, there will be more to come about this one on our next webinar. Once we have more information about what the expectations are going to be from a documentation standpoint. Right now, I'm going to turn it over to Nancy for telehealth.
Absolutely. So as we said at the beginning of this webinar, changes in information is literally coming in hour by hour, and this is what we have at this time, with more to follow. So if we had it, we'd give it to you. Unfortunately, as Angela said, some of this is still in the works, and we're all in the same boat together here on this one. So telehealth. Yeah, great service. People love it or hate it. Either way, it is what we have now. As we are all aware, telehealth came very important during COVID. The COVID has now ended officially. The pandemic is officially over as of May of 23. New changes came in through the COVID as of November 23. So of course, now that all of the pandemic and the emergency use is all off the table, telehealth is one of those first areas that are going to get very hit on audits and reviews. And we're already starting to see that. We're seeing that overbilling has become an issue because, again, when telehealth became a thing during COVID, there wasn't a whole lot of guidance at the very beginning. People started doing it and guessing, and then they were getting information and then still guessing. And now it's being realized that as the information is being audited and reviewed by either a CMS or an external commercial payer, that these were probably, and most likely overpaid due to poor documentation. So CMS uses every tool that they have to lower the risk of fraud and abuse in the Medicare and Medicaid programs. And they have decided that telehealth is one of those areas that they need to start cracking down on. So just be aware that there's very specific criteria that needs to be in the documentation to support the reason for a telehealth visit. And it sounds like a broken record, but I know that some EMRs have the ability to do some, those dragons or the templates. If you have a good template, a compliant template, we would recommend using that to make sure that your practice is effectively doing what is required to make sure that you do not get hit by a fraud and abuse, which is probably more likely an overcoding of services where information may or may not be have made available. And on the bottom of this slide, you can see that we are referring back to the AAPC brief on fighting fraud. The telemedicine investigations are on the rise. So this is something that's very hot and heavy in our everyday life now, and we just wanted to make sure that it was made aware to you as well. So here's some examples of telehealth. The patient was seen on a telehealth visit. The patient is being seen through a HIPAA-compliant video telemedicine platform. The patient has provided consent for medical evaluation and treatment. I discussed the limitations of the evaluation and management by a telehealth. The patient expressed understanding and agreed to proceed. So that is some compliant language. Additionally, some more compliant language is the patient remainder of the interview was conducted via telephone due to audio issues. Now, obviously, we're all aware that technology is wonderful, but it does have limits and it can cause problems. Sometimes, especially if you're dealing with patients or people who don't necessarily have the technology background that some others do. And I'm going to pick on my parents now. You put a computer in front of my mom and she has no idea how to do it, but my dad could basically probably work for Apple at this point. So, and they're in the same household. So some people are more comfortable with telehealth visits and some are not. However, if the video component is no longer working or was not available, it does need to be documented that that is why a telephone was switched to a telephone or an audio visit only due to any technical issues. The call was placed at 3:43 p.m. and 53 minutes and 56 seconds were spent on the phone. 13 minutes were spent on video and 10 minutes to review the chart. Again, they're very specific times. So telehealth not only requires telehealth compliant documentation, but if you want to include time component, again, we're referring back to the time that we already talked about on our previous slides, very specific time documentation as well. And I am going to let Angela take modifier 25. She likes this one too for some reason.
Yeah. Well, and we know how much the payers like it, that this is one, it's every payer, because modifier 25 is still the most misunderstood, most misused, which of course in today's world of data analytics, payers are getting pretty smart and they can tell every time a modifier 25, if they see a modifier 25 always being billed with a certain procedure, you better believe they're going to be looking at that, because that doesn't make sense. So let's start off by actually looking at what the AMA says about modifier 25. Because this, with everything that happened with Cigna this year, saying that, they were going to start, actually requiring documentation be submitted anytime you used a modifier 25 and all that craziness, they actually, not only did they do a CPT assistant on modifier 25, but they also put out a booklet or a toolkit. And it is also, the link is also on our resource slide. And I think the thing that probably after I read it all, and even after you read some of their examples, the one thing I think out of this entire document that to me was the most impactful was this little bulleted list they provided. And it says, pre and post-operative services typically associated with the procedure include the following and cannot be reported with a separate E&M service code. So the reason I think this is important is, look, it's the review of the patient's relevant past medical history, the assessment of the problem area to be treated, formation and explanation of the clinical diagnosis, review and explanation of the procedure with the patient, family, or caregiver, discussion of alternative treatments and diagnostic options, obtaining informed consent, providing postoperative care instructions, which include any further treatment or follow-up after the procedure. So, I mean, if they're prescribing post-op, pain relief, it's part of this. So that is one reason I believe why so many providers are now being targeted. Let's talk about my favorite one, orthopedics and joint injections. Patient comes in, they've been having knee pain forever. And so finally they come in and the physician reviews past history. They do the assessment of the problem area. They talk about treatment options. They get, if they decide, well, you could have a joint injection, or we could try conservative measures, or we could try PT, or we could try this. As you talk about what is being done, that's exactly what was on the previous slide. So that is why orthopedics and E&Ms and joint injections are often a target of payers, because if you look at what the global period is and you look at that, because remember, the 0, 10, and 90-day global, every E&M every procedure basically has some form of an E&M built into it. And that is why it's so important that that evaluation and management service needs to be separately supported and be able to stand on its own. And I know this is an extremely busy slide,
And we're
but
not reading it word for word, trust me.
no, we're not going to.
No, we'll put you all to sleep.
Yeah, well, and the other thing is, this is basically just an example of putting an E&M code with a procedure that's going to end up with a denial. Because truly, if you look at this, this does not have a separately identifiable evaluation and management service. This patient is following up for left knee pain, and she wants an injection, and everything is good. Nothing else new is going on. There's no separate E&M service even performed here. So in this example, an E&M isn't even supported. Now, Nancy, you want to take over the conundrums?
Oh, sure. You just wanted to say the word conundrums, didn't
I
you?
love that word, conundrums.
Yes, I would love to talk about conundrums. If you're a coder, you're aware of this, but we are not clinicians. We might have the same knowledge, but we are not able to actually diagnose or treat a patient. And some of those patients are probably very happy that we are not. So complexity of problems addressed. Coders cannot code things that are not written down. You may have done it. It may be implied that it's been done, but unless it's actually documented, we cannot count it towards your MDM or your problems addressed. So the level that we choose on your behalf as a provider, it has to be based on the documentation for the illness, condition, or injury being addressed. Per the AMA, we are not allowed to determine it. We could have a great relationship. We might understand that you might have meant to do this, but as a coder, we cannot code something that is not there. And I keep saying written because I started out when physicians were actually writing their notes, but now everything's pretty electronic. So it does need to be documented, whether you're using Dragon, a template, or a scribe, anything like that. It just remember, if it's not documented, it did not happen. The patient's physician or QHP is expected to determine whether the medical problem or illness is stable or worsening. We are also not allowed to take a lab value that's a high or a low and infer if it's hypo or hyper based on the lab value setting itself. It needs to be documented by the provider or the QHP in order for it to be a stable, acute, or worsening condition. So we like to say that as much as we can to make sure that it is very well known that it does need to be documented. Is it chronic, low, moderate, or high? Are clinicians using terms to support the correct levels? Acute or chronic, acute on chronic. Again, these seem to be adjectives that people are very, very comfortable using, but they can be also used in the same sentence and mean two different things. So we just want to make sure that it's putting out there, that if it's not documented appropriately, we cannot count it. Or if it's misleading or contradictory, we would need some clarity. So we tried to provide some buzzwords for you: not at goal, unstable, uncontrolled, not responding to treatment, failing to progress. So these are things that if these adjectives or descriptors are included in the overall documentation, it will help support the problems addressed, as well as getting you to the absolute most accurate level possible. And this slide will be provided as well, so you'll have reference to this as moving forward. Next slide.
Okay, I think this is where I get to jump back into the swimming pool. So surgery risk. This is one area, kind of like prescription drug management, that everybody has been begging, the AMA to make it clear for, us coders, et cetera, so that there's not this great divide between payers and, the healthcare, provider. Because the tighter the guidelines are, the more level the playing field is, as far as we're going to look at everything exactly the same way. As we all know, there's still some gaps. And when it comes to what is a major versus a minor surgery, this is one of the things that, we were hoping that we as coders and auditors would get like a really good definition, and we didn't. And so one of the questions that was submitted to the AMA was, does a physician or QHP need to specifically document or use the terms major or minor surgery to clearly differentiate the two classifications of surgery? Because remember, in the guidelines, it states it's not based upon the surgical global period, which a lot of groups that I've worked with over the past, few years, to make it easier for them, they're using the global period to determine major or minor. But the AMA said, basically, yes, it is recommended that the physician or the QHP should document whether it is considered a major or minor surgery, because the classification into this major or minor is based solely on the common meaning of such terms when used by a trained clinicians, which coders, we are not trained clinicians, or most of us. These terms are not defined by CPT coding surgical package classification. So if, maybe you as a coder are struggling with your physician, trying to determine whether it's a major or minor surgery, maybe this is a good slide to take back and say, hey, did you know even the AMA says it's really going to be helpful? Because if you think about it this way, when a payer looks at it and it's not clear, what do you think they're going to do? They might default to the minor, when it may be, in the grand scheme of things, it is a major surgery. The next thing I want to talk about is the risk. Risk. So there was also a question posed about risk, because it's also extremely complicated. A lot of physicians, a lot of documentation that we see, when the decision for surgery is made, it's a macro that's the same for every single patient. And the macro could be very vague. It's, I've discussed the risk, the complications, et cetera, of the procedure, and the patient agrees. As a coder or auditor or a payer, you didn't even tell me what they were. So how do I know if this is minimal, low, high? How do we know? So it's, one of the questions was, do the inherent risks, like example of perforation, make surgeries high risk to patients when selecting the level of risk for decision making? And so there's a lot of work, there's a lot on this slide, and you'll get the slide, but I think the things that I highlighted are what we need to focus in on. Because they say, however, a relatively simple procedure for an otherwise healthy adult carries a different level of risk than the level of risk for an older patient with multiple comorbidities. So you can't just say that, let's just say this procedure is always going to be high risk, when if it's done on a really healthy individual with no conditions or complaints, then technically it might not be high risk. So it's really important that the documentation really shows not only to the coder or the auditor, but even if a payer gets it, that they're going to see that how that risk of that procedure or that patient's comorbidities are going to affect the level of risk. And they even go on in one of their other Q&As, they even recommend the physician state that this surgical is high risk due to, or the surgery is moderate risk due to. Then that way it's unique to the patient and it's not the same on every patient. The other part is here, as I bolded, as a result, the physician documentation of her level of risk assessment based on specific patient risk factors in determining the component and how the MDM level for risk for that specific patient is calculated. So, and then it goes on to say, well, remember, it's 2 of 3. So the risk, you still are going to have either the same level or higher in the other 2 categories. So either problems addressed, data, or risk. Okay, so our next poll question is, what is your favorite aspect of coding and auditing? And you can just go ahead and put that in the Q&A, since we know the chat is not functioning right now.
Well, I think we know some of Angela. She loves modifier 25. It's crazy talk. Mine is I like learning new things. I've been doing this for a very long time, and there's still some drug or diagnosis that comes out that I have never heard of, and that gives me the opportunity to go and do some research and to learn about it, and especially the those ones that are more hereditary, or they might not come out until a patient's adult, and those kinds of diagnoses that the patient didn't even really know that they had, and then all of a sudden it's determined based after study that they have some rare condition. So I always like to look those up to make sure that I have at least a working knowledge of some of that stuff. And it also helps with Jeopardy questions. So let's see what we have some of those answers. Angela, you are on mute, my friend.
Oh, I'm off now. So, pain management, E&M. Oh, good Lord. Whew.
I like that. I like whoever helping patients and getting paid. I like that
Love
one.
that. Ooh, and there's a couple people learning new things.
Yep. Research, mysteries. Yep. I'm with you, Heather Smith.
Regulatory issues.
Love. Yeah. So Jacqueline Hunt, you have indicated that you like putting pieces together. Every day is a new opportunity. And you know what? And I can speak from experience, regardless on how long you've been in this field, every day you are going to learn something new. And it's one of those fields you can't, it's not black and white. Like Angela just said, surgery, depending on a 25-year-old or an 85-year-old having the same surgery, one is not as high risk as the other. Coding's the same thing. Whether you've been doing this for a month, a year, 2 years, 20 years, you're still going to learn new things every day. What do we have on the next slide, Angela?
Oh, so since we knew, and we have, everything like Nancy has said has been changing, and we know that the final rule is out. We have this summary of everything that was done. The problem is that as we all know, the final rule a lot of times is not crystal clear with what the documentation requirements are. So right now, everybody's kind of in a holding pattern, waiting for Medicare or CMS to get the change requests to the max, so we can kind of see what the guidance is going to be on what CMS fields the documentation requirements are going to be. We've got a lot of there's some new codes this year for caregiver training. There's this PIN, which is Principal Illness Navigation. There's the CHI, which is Community Health Integration Services. There are so many kind of new things that they're going to be paying for that aren't necessarily, it's not a physician providing the service, and it's not a QHP, but it could be, somebody within the community that is navigating services and helping patients. So our next webinar, when we have more information, we're going to really focus on those topics to help you understand what's going to need if you decide you want to actually provide and document some of these brand new services.
Great. So
Excellent. So
we got some great questions. So Nancy, go ahead. I know that's where you're going.
yeah, absolutely. Thanks, Joe. Yeah, we have about 5 minutes left to the top of the hour. We don't want to hold anybody from more work or their lunch. So I'm going to go through a couple of questions quick. One of them was on a telehealth, and it says, does medical necessity need to be documented in order to have a telehealth visit? Well, as you could see on the slide that we just said, there are some new changes coming in 2024. In current, meaning today's view, medical necessity necessarily does not have to be documented. However, the reason for the visit does. So whether it be a med necessity issue or not, telehealth is still applicable as of December 14th, 2023. January 1st, that might change. So as of today, med necessity is not necessarily required. However, it is required that the reason for the telehealth visit is clearly documented, as well as the mode and how many minutes. So it's kind of a double-edged sword. Med necessity, no, but reason and complexity, yes, if that makes any sense. Great question.
Well, and I'll add in there too that some of the payers, remember, require you to, and you need to make sure that you're aware of this for your payers, require you to document why it's being done telehealth, why they couldn't come to the office. And if you kind of look at it from that standpoint, that is, you could almost imply that the payers are asking for the medical necessity for why it's a telehealth call, why they're not in the office. So just be aware that some of the payers, now that the PHE is over, is actually requiring that.
Excellent. Thank you for that clarification. I think I meant to say that and it came out a different way. Angela, I have one for you. Why is modifier 25 being targeted so much?
Well, again, I think what it really boils down to is the fact that now that you've got all of these companies that can do data analytics and the payers are really looking at things, they can target and they can look at, okay, how often is modifier 25 being billed with this procedure code? And they'll look at the diagnoses and then they'll go, but wait a minute, because remember, anytime you do something the same way every single time you do it, it throws up a red flag, because modifier 25 isn't always appropriate every time you give, every time you do a lesion removal, or a modifier 25 isn't, a separate E&M isn't supported, every time you do, you put sutures in a patient. I even think there was an example of, I'm trying to think of the example. It was an emergency room visit. There was actually an emergency room visit, and patient came in and they said, can we bill an E&M for like doing sutures? And the answer was basically, if all they're doing is just evaluating the patient and putting the sutures in, no. But now maybe if the patient fell and hit their head and now you're working them up for a completely different problem, then a separate E&M would be supported. So I hope that kind of makes sense. They're going to be looking for something different that is being evaluated, in my opinion.
Yeah,
Excellent.
Well,
we're at the top of the hour, Joe.
Yep, we are out of time. Thank you. So I want to thank everybody for joining. As long as we have your email address, you will be getting a response from us. You'll have your CEU credits, and we will answer all the questions that were asked. In the meantime, or even after you receive our answers, if you have any questions, if you think of anything, send them over, and we will be thrilled to work with you. Or to engage or help you answer those questions. Again, thank you so much for joining. And we look forward to our next session with you all.